use something called an open circuit nitrogen washout method or a closed system helium dilution method. So those are for, as I said, a pulmonary clinic or a department that doesn't have the ability to obtain a body box and maintain all that technology, but it does allow them to still measure that residual volume so you can get the functional residual capacity and the total lung capacity. These two systems, these two methods, I should say, are not as accurate as a body box, but they do still give a pretty good predictor of what it will be. So I want you guys to take a look here. This is a picture of a normal lung, and we're looking here at the different levels. So take, for example, here would be our inspiratory reserve, our tidal, our expiratory reserve, and our residual volume. So it's kind of hard to distinguish between the inspiratory reserve and the tidal volume, but it's this section right here. What do you notice about a patient on the left side? What do you notice about that patient's expiratory, or their functional residual capacity? So the expiratory reserve volume and that residual volume.
It's a lot bigger.
It's a lot bigger. And why do you think that is?
There's an obstruction.
Yeah, there's an obstruction. So they're not able to exhale. So they tend to hold in all of that air. So that's what we call air traffic. Very good. So here's a picture of a body box. Okay. So that body box will measure all of the volumes and capacities. So when we look at the total lung capacity, it's the maximum amount of air that the lungs can accommodate. So it is a combination of both inspiratory capacity and their functional residual capacity. It can be measured via the body box, the open circuit nitrogen washout, or the closed circuit helium dilution test. And if we're looking at the total lung capacity, okay, so that's the whole lung. Here is a normal sized lung, and here is an obstructed lung. Okay, what do you notice about the obstructed lung compared to a normal lung?
It's bigger.
It's bigger, exactly. Why, physiologically, would that be a bigger lung?
Because of the air trapping.
Perfect, because of air trapping. Now let's contrast that. Here is a normal lung. Here is a restricted lung. What do you notice about the restricted lung?
Small.
It's a lot smaller, okay? So can somebody give me an example of a restricted lung?
Asthma.
Asthma is actually an obstructed lung, okay? So when someone has an asthma attack, they can breathe in all they can, but they can't exhale it out.
Anaphylaxis.
Anaphylaxis is the same thing. It's really when the airways constrict, okay? So that would also lead to significant air trapping. Go ahead.
Could it be like a collapsed lung, maybe?
Absolutely, and absolutely. Any type of condition that can cause a collapsed lung. Okay, so pneumonia, anaphylaxis from people hypoventilating and not taking big deep breaths. It could be from, you guys remember in fundamentals when we talked about scoliosis, kyphosis, lordosis, pectus, yep, carinatum, pectus excavatum. All of those lead to restrictive lung disorders. In general, COVID-19. What does COVID lead to? Very commonly, it can lead to ARDS, acute respiratory distress syndrome. Okay, you guys remember from your Mod 1 exam, you did those essays, and you really looked at this, a lot of the physiology involved with COVID. So due to that extra fluid buildup and inflammation around the lung, that could really be significantly restricting that lung. And that's why people end up with long-term damage, okay, because their lung, the functional amount of it gets reduced. Okay, so one of the things that's clinically significant, as we said, the residual volume should only be about 20% of the total lung capacity. So if you see that as a percentage, it's literally just the residual volume over the total lung capacity. And that should be about 20%. That will be increased as obstruction in airways and air trapping increases. Okay, so that's what we're looking at when we're looking at the different volumes compared to the anatomy of the lungs. So we're looking here, this is a tidal volume, meaning just a nice quiet resting volume. If I told the patient, hey, take a big deep breath in, they did, and they went up all the way up into the inspiratory reserve volume, and I said, exhale out as much as you can, and they took a really forceful exhale. They would get down into their functional residual capacity until they reached residual volume, and then they would exhale and go back to their tidal volume, okay? So you could match that up with the lungs themselves, and it's showing here how as alveolar pressure on inhalation, in generally we breathe through negative mechanics due to the drop of the diaphragm, the intercostals expanding out, creating that larger volume in the thoracic cavity. And due to Boyle's law, it says if volume increases, what does the pressure do? It goes down, very good. It decreases. Okay, so those are indirect relationships. And that's how we really create like a vacuum pressure for our lungs. Okay, so we do that, and then when we inhale, we get that positive pressure. And so this is looking at our volume, our pressure relative to the atmosphere, so our alveolar pressure, excuse me, compared to atmospheric pressure. And then this one is looking at our pleural pressure, which of course has to go negative to allow us to take our breath in. Okay, here's another picture of that. So originally the spirometers were really looking at volume displacement, okay, and they had very simple basic spirometers that used to do that, and it literally, based on a little bellows system, would graph out. Now we have really cool machines that we'll take a look at here. So the first thing we'll talk about is our forced vital capacity. So the forced vital capacity is the maximum volume of gas that can be exhaled as forcefully and rapidly as possible after a maximal inspiration. So everybody do a forced vital capacity. Exhale everything out. Now take a big deep breath in and blast that out. Of course, socially distanced. Very good. Good job, you guys. Okay, so that would be decreased in both obstructive and restrictive disorders, and it can be measured with this flow volume loop. Okay, and this is what we're going to look at. This would be our patient taking a breath in, and up here at the very top of exhalation, they would blow out as hard as they can. Now they should be blowing all the way to 6 seconds here, but they only blew to about 4.5 seconds, which is okay. And then this is the inspiratory portion. And this flow volume loop is what we're going to work on and measure via spirometry. Okay, so here's some examples of flow volume loops. When you want to get a good flow volume loop, according to American Thoracic Standards, in order for this to be a valid test, you need 3 reproducible samples. Okay, so you need to take the test 3 times, and they need to be within 150 milliliters of each other to say they're reproducible and just to get an accurate test. an FEV number, okay? So clinically, the most common one is looking at the patient's forced vital capacity and then looking at that first 1 second, and we can see how much volume was forced out. Okay, so that same loop here, the FEV 1/2 second, 1 and 2. So naturally, all of us should be able to, within that first 1 second, really open up our lungs, and when we do that forceful exhalation out, if we have good musculature and patent airways, meaning open airways, we should be able to forcefully breathe out 83% of all of that volume in the first 1 second. Okay, so if you can't, why do you think that might be? What are some of the things that might prevent you from being able to get that volume out in 1 second?
The elasticity within the alveoli.
Perhaps.
Would that kind of be like the air trapping, right?
Okay, right. So it would actually be commonly the airways closing up. Okay? Very good. So when we have somebody with an obstructive disorder like asthma, then they might have they might be a little bit better at the slow vital capacity. So somebody with an asthma exacerbation or COPD, okay? This is one of the most clinically significant tests you guys are going to look at on spirometry, and that is the ratio between your FEV1 and your forced vital capacity. So this is called your FEV1 percentage, or you might hear it just called the FEV1 ratio. So in this test, or in this reading, you're looking at the ratio of volume of gas forcefully exhaled in 1 second compared to the total volume of gas that can be forcefully exhaled after a maximal inspiration. In other words, your vital capacity, your forced vital capacity. This is very important. It will be decreased in obstructive disorders, and it will be normal in restrictive disorders. So let's think about that. This number, the ratio, would be normal in restrictive disorders. When we have restriction, we learned that our compliance is really stiff, right? So it's really kind of hard to take a big breath in, okay? And especially if we have an anatomical restriction, we really couldn't take a big breath in, could we? We really couldn't. So could we get that forceful breath out? No, but comparatively to what we can take in, the patient could most likely get it out because their airways are patent. Okay, so that's why this FEV1 ratio would be normal in restrictive disorders. Now in obstructive disorders, they have a high compliance, meaning they love to bring air in. But then it gets trapped in there because they start bronchoconstricting when they try to exhale that out. So that's where they would take a nice, good forced vital capacity, or inhalation. But when they did that forced vital capacity, the air gets stuck in there. So it would take them a lot longer to get that air out. From that, we're going to look at your flow volume loop. So when we do that forced vital capacity, it's going to create a loop on our spirometer. And that is just a graphical analysis of the forced vital capacity followed by a forced inspiratory volume, and that produces the curves. And that's that flow volume loop. Okay, this is what a flow volume loop would look like. Here would be the exhalation, so this stands for peak expiratory flow rate. That's the maximum amount of flow up here. And this patient, you should have patients breathe out until approximately 6 seconds. This red line right here would be representation of a normal flow volume loop. So this one is one we would call scooped out, meaning that if you look here when they start breathing, see it takes them a really long time to be able to exhale out of their breath. And that's generally due to obstructive disorders and airway trapping. So they have what we call airflow limitation or dynamic compression on exhalation. So here we go. Here's a flow volume loop of a normal subject, okay? This one is a little bit diminished, so this patient is a little bit older. And all of our lungs, anybody here over the age of 25? I hate to tell you, we're already starting to lose our function, okay? It peaks at 25, and then our lung function decreases. That's why it's really important for us to all stay cardiovasculature active so that we can really work on decreasing that faster aging process. This one would show moderate airflow limitation with a subject with asthma. And this one, what do you think? This would be severe airflow limitation.